Welcome to Epstein Becker Green's webinar, Alignment and Simplification of Quality Measures Across Markets, the second installment of our Value-Based Payments Crash Course webinar series. We are pleased to have Epstein Becker Green's Richard Hughes, attorney in the Healthcare and Life Sciences practice and strategic advisor with EBG Advisors. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. At this time, I'd like to turn the webinar over to Richard.
Good afternoon. Today we're going to take a quick, high-level look at government and private payer efforts to align quality measurement across markets toward achieving more meaningful quality measurement and reducing the burden of quality reporting for providers. First, we'll briefly discuss the past and current quality measurement landscape. Then, we will review some of the recent efforts by CMS and private payers to align quality measurement across programs and markets. Finally, we will consider macro developments and the focus of quality measurement in the future. And just to note that in our next webinar in this series, my colleague Leslie Young will discuss macro extensively. So just to give an overview of the current quality measurement landscape, not much attention was given to measuring quality before the late 1990s. Some measurement existed thanks to the pioneering work of people like Avitas Donabedian, who gave us the familiar measure categories of structure, process, and outcomes. But it was these two groundbreaking reports by the Institute of Medicine that would call attention to the unacceptable breakdown of our healthcare system, both in terms of failed outcomes and jeopardized patient safety. Undoubtedly, last week's headline that medical errors are now the third leading cause of death in the United States will lend new force to this continued national discussion. And then, of course, IOM's recommendation that efforts be made to develop measures for the assessment of quality of care. This led, next slide please. This led to a major proliferation of organizations developing measures. As we see here, this includes accreditors, agencies, organizations that are devoted entirely to quality measurement development, as well as individual professional societies. The number of quality measures generated by these organizations totals in the thousands. Thankfully, the National Quality Forum culls this number down to around 600 with its endorsement of measures that have a supporting consensus. The NQF endorsement is considered the gold standard for quality measurement. Next slide, please. But there have still been challenges with the volume of measures and lack of measure alignment across government programs and markets, which makes it hard for providers to keep up. Medicare maintains measure sets for over 30 programs. States impose varied requirements for private plans and Medicaid managed care plans, and qualified health plans must submit quality data to be certified. The lack of measure alignment across these programs and regulatory requirements is astounding, as there has been little consistency in the selection of measures. One study found that 1,367 measures were in use across only 48 measure sets sampled. Adding to the already substantial confusion and frustration among providers over measurement, payers, including CMS, often modify measures. In 2014, it was found that over 1,000 measures were in use across 33 different CMS programs, and half of those were unique measures. And of course, some measures do not facilitate the most desirable outcomes and can even incentivize bad care. There is also a growing consensus that too much measurement emphasis is placed on structure and process and not enough on patient outcomes. Finally, there is the long-held concern that there is no meaningful way for patients to use measures in making informed decisions because there are so many measures that comparison is just out of the question. And often, measure complexity does not lend easily to consumer-friendly information. Now, to look at some of the recent and more significant CMS and industry efforts to align quality measurement sets across programs, these are largely being driven by the aforementioned concerns with the volume, variation, and questionable utility of measures. And then there's the macro legislation, which requires CMS to consider how it can incorporate private payer and integrated delivery system measures. As a result, CMS has made efforts in recent years to better align measures across its programs. These include the Measure Applications Partnership, or MAP, a public-private partnership through which NQF advises HHS on pre-rulemaking measure considerations. Its goal is to streamline measures and facilitate alignment. In a 2016 report, MAP emphasized that measure alignment is one of the most important cross-cutting priorities. The Healthcare Payment Learning and Action Network, which is a broader effort to convene and facilitate alignment of payment models across payers. And then among these initiatives is the Core Quality Measure Collaborative, which we will highlight today. The collaborative consists of CMS, multiple private payers, and AHEP. Together, the payers represent 70% of enrollees in private plans and Medicare fee-for-service. As the collaborative has had success in the development of multi-payer core measure sets, we'll take a look at how they have approached alignment of measures across markets. Next slide, please. So the collaborative's mission had three aims. The first aim was to reduce the total number of measures, and in the process weeding out the low-value metrics, and to introduce consistency across payers. Second, to refine the remaining measures to make collection easier. And finally, to relate measures to outcomes, particularly measures that matter. So in evaluating measures, the collaborative applied 10 criteria that are listed here, with an emphasis on alignment with NQF goals and endorsement status, easing data collection, and reducing the number of measures in a particular measure set to less than 15 where possible. The collaborative had a preference for measures currently in use, but those with an ability to actually drive improvement, as well as those that are cross-cutting. We also see an emphasis on measures that can produce useful information for consumers, measure the patient experience, and of course, outcome measures. And so the collaborative has produced 7 version 1 core measure sets released in February of this year. These 7 sets are downloadable from the CMS website. Other core measure set categories are currently under consideration. Most of the measures included in the sets are already in use. The core measure sets will evolve over time as new measures meeting criteria emerge. And for each measure set, the collaborative identified future areas for measure development. These are listed at the end of each set. The streamlined core sets are expected to significantly reduce reporting burden for providers. For example, only 21 measures are applicable to primary care providers. CMS will implement these sets across programs through the rulemaking process. While this was not a feature of the recently released final Medicaid Managed Care rule, CMS did emphasize the need to include these core measure sets in the recent proposed macro rule for the new Merit-Based Incentive Payment System, or MIPS. CMS does intend to supplement the core sets with other measures in order to address specialty gaps and targeted population needs. As for commercial payers, the expectation is that the core measure sets will be phased in over time as provider contracts are renewed or where modification is allowed under current terms of contracts. So now, to look ahead to areas of quality measurement emphasis and future developments, as mentioned, CMS recently released the proposed rule for macro. Of course, macro itself represents alignment of Medicare value-based purchasing programs by consolidating the physician quality reporting system, value-based modifier, and meaningful use programs. As for quality, under the macro legislation, CMS is required to provide a strategic framework, vision, and expectations for measures to address the quality performance category within MIPS. And fulfillment of this requirement, last week CMS released its Quality Measure Development Plan. Additionally, CMS announced in the macro proposed rule that it will continue to accept the submission of proposed quality measures and measure updates. To be considered for inclusion in the annual list of quality measures, submissions must be made prior to June 1 of each year. Through this process, CMS hopes to continue developing an aligned measure portfolio. The macro legislation also requires CMS to emphasize outcome measures. So we will see a continuing shift away from process measures toward outcome measures. Additionally, CMS will continue to emphasize other high-priority measures, including appropriate use, patient experience, safety, and care coordination, as well as cross-cutting and specialty-relevant measures. As measure sets evolve, CMS will engage additional non-payer stakeholders, including provider and consumer groups. Now, as far as reporting under MIPS, providers will have flexibility to choose measures from applicable measure sets, this is under the proposed rule, and would be required to report at least 6 measures, including at least one outcome or other high priority measure, such as appropriate use, patient experience, safety, and care coordination. Groups of 25 or more would be required to report on all measures in a set. Ultimately, all of these efforts will impact how providers are measured under MACRA's future alternative payment models. Finally, as mentioned, consumer quality information is an area that has been hampered by the sheer volume and variation of quality measures. If the foregoing alignment is successful, we can expect to see an increasingly better ability to make meaningful data comparisons and a push to make information available to consumers. The core measure sets produced by the Core Quality Measures Collaborative are a tangible and promising first step toward greater measure alignment across multiple payers, spanning government and private payers. But the ultimate success of its efforts will depend upon payer implementation efforts and the rulemaking and provider contracting processes. Thank you all very much.
Thank you for this wonderful information. It looks like we still have a little bit of time left, and we do have a question that came in, so I thought we might use this time to address that question. Someone has asked us, multi-specialty groups have a particularly difficult task in identifying measures applicable to all. Is there a plan to address this issue?
Yes, I'd be happy to follow up with you. There is some language in the proposed rule around how to address this and how to address subspecialties. So if you'll send me an email, I would be more than happy to follow up and discuss it.
Great, and I'll let you know who that person is as well. Wonderful. All right, so this concludes today's webinar, and approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We also have a few upcoming webinars, as you'll see in the coming weeks. We have physician payment reforms, the future of MIPs and AMPs, that's next week, followed by 2 additional webinars to round out our month of value-based payment crash course series. We hope everyone will be able to join us. For additional information, you can visit www.ebglaw.com/events. Thank you very much.